topic which is given to me is again challenges in implementing the program, right? So Kaustubji rightly he mentioned that the program it was initiated way back in 2008. So this I will put forward. Okay, so precisely I will mention about this program and then so what are the challenges and what is the way ahead. Okay, so these issues we will focus much upon. And when we see about, okay, I'm not speaking anything about the global scenario, so you can see how the traditional systems of medicines they are being accepted, otherwise the global pendulum of the global population is moving towards the traditional systems of medicines. You can see the what I can say, it's a cross section of the globe if at all you are looking, you suppose. So the green indicates that there is some sort of right policies are existing, or people are accepting, or people are using some sort of traditional medicines for their healthy, okay, health purposes. So you can see that, okay, so across the globe, majority of the countries they occupied with green, they have been colored in green, okay, so they have been depicted in green. It indicates that all those countries, they have some sort of policies, they are accepting traditional systems of medicines. Of course, so this belongs to 2018, almost 7-8 years back data it is. Of course, okay, so but this is the only updated data which is available on the World Health Organization's website. So we can say that yes, this is authentic for me. Until and unless if that 2024 and 2033 document is not coming up, until then this is the valid document for us. So it says that majority of the countries they are accepting traditional systems of medicines at some part of their life. So it indicates that yes, okay, so demand is moving. So these two are the important documents. As a traditional healer, so let it be Siddha, Ayurveda, Homeopathy, Unani, whomsoever they may be, right? So they have to refer this document, these two documents. Of course, that decade document, again, as I said, the first screenshot is from this 2014-23 document. Of course, this is, it won't be valid after a year or so. After 2025, it won't be valid because by the time 2025 ends, you suppose, the new document, new decade document will come into force. WHO it is working on that, and so the draft is already, okay, so it is reviewed, and possible that, okay, so by the mid of or by the third quarter of 2025, the document may come into force. By, okay, until that time, okay, so this document is Bible for you. What it says that, okay, so need to strengthen the safety. They also say, okay, so they also reinforce that there is no doubt that traditional systems of medicines can definitely contribute to the sustainable development goals. They significantly can contribute to the global healthcare needs, but okay, so what they say is they need to be strengthened their safety. This is what I was mentioning, okay, so in the morning, that LSHTM ashwagandha we have exported by the name of ashwagandha drug as a drug, but okay, so we were faced about 1.5 years. We have struggled for 1.5 years to answer the queries, to say that yes, it is safe, to say that yes, okay, so it doesn't have any adverse drug reactions, to say that yes, we have monographs for ashwagandha, to say that yes, quality profile is established, right? So that's what the WHO is also saying, that okay, for each and every molecule, for each and every formulation, for each and the raw material, you need to have the quality profiles, you need to have, okay, so the safety indicators, you need to have the proper use, how to use it. Though it may be a quality drug, it may be a good medicine, but if at all it is improperly used, you suppose, okay, so what is going to create, okay, what kind of inconvenience is going to be created. Okay, so this is what this says, that use the drug in an appropriate manner. How it is to be used properly, okay, so that documentation is supposed to be generated. Okay, so this is what the WHO is saying. And at the same time, so this is one of the APW that was conducted under the banner of CRO, Southeast Asian Regional Office. APW activity for performing work, okay, so that was done by in 2019. That was a project report of APW which was done by we people. They says that document the observations for making recommendations. They says that so if your Siddha medicines, if your Ayurveda medicines, if your homeopathy medicines or Unani medicines are safe, you suppose, you document it. I may be speaking over here, it is volatile, so whatever I spoke is gone with the wind, right? So if at all it is written on a paper, you suppose that paper will speak, fine. So that paper they need, the documentation they need, that systematic documentation they need, that Kudiniru, otherwise whatever it may be, Siddha medicine, okay, so it works wonderfully in COVID. Whether it is written, whether it is published. If it is published, definitely the global populations, they will accept it. But if it is not published, if it is not documented, then WHO also they says that yes, okay, so we do understand that Kudnir will work. But okay, so if there is no document to support, then it is difficult to me to convince the global population that yes, okay, so this formulation is a wonderful drug to counter those viral pathologies. Fine, so this is what that document says. Pharmacovigilance and traditional and complementary medicine in Southeast Asia, a situation review. So it was done in 2019. Sorry. So with that, so traditional systems, you know it very well. And pharmacovigilance, okay, so when it came into force, okay, so it came into force in, okay, so you can see 2006 and onwards, okay, so there was a huge cry. People, they started to think about traditional, okay, so pharmacovigilance systems for traditional systems of Ayush products. Of course, okay, so 2000 and onwards, WHO and so other regulating authorities, they started to think on pharmacovigilance for traditional systems of medicines, right? So you can refer, okay, so all these documents, okay, so which are floated over here, all the documents, they are available freely on the web. Okay, so you can, okay, they are openly available on the website. You can go to those WHO and then you can download them, you can read them. You can, okay, so right, strengthen yourselves, right? So 2000 and onwards, okay, so there are concepts, okay, so they have thought of implementing pharmacovigilance systems for traditional systems of medicines across the globe, not only in India, but okay, so in India you can see in 2006 that rational use of medicines for Indian systems of medicines, right? So it was initiated, okay, so in 2006 in Aligarh Muslim University, right? JN Medical College, okay, so they have conducted a program and then in that program, so they have given what I can say recommendation, okay, just like this program will come out with some recommendations. So one recommendation, it came out from Aligarh Muslim University, so that was for the first instance where pharmacovigilance for traditional systems of medicines in Indian scenario, so it has been highlighted. So after that, okay, so in the same time, so in Mumbai, that Ayurveda update, okay, so Urmila Thatte and group, okay, so these people, they have organized another program. They also came out with similar kind of recommendation, based on which in 2007, okay, so in the month of December, okay, so this program was organized by Professor M.S. Baghel and the team. They have organized, and in that event, the Dr. Chadha, okay, he was the director at that time of Ministry of Ayush, okay. So he came to that event and he said that, yes, okay, so program is organized, but this program is supposed to be materialized. So it has to become a national movement, okay, so this is what he said in that program, and then he initiated it, and so it became a national program in 2007 and 2008. Of course, okay, so again this program, it was re-strengthened by Katoch sir and other people in the Ministry of Ayush, and now you know it very well, okay, so that is since 2018, okay, so it is functional. And this is the hierarchy. We have this hierarchy, and we have 98 plus 1, 99 peripheral centers across the country, and we have these 5 intermediary centers, and we are representing NIS, Siddha system of medicine is being coordinated by the intermediary coordinating center, and then National Pharmacovigilance Coordination Center is situated at All India Institute of Ayurveda, and then above that we have drug policy section. So this is the hierarchy which is existing. So you can see the screenshot, otherwise cross section of the country. Across the country, so there is no state or union territory which is devoid of pharmacovigilance centers. In each and every state, in each and every union territory, we have one or the other pharmacovigilance centers. You can go to any state, so you will have one center. It may be, okay, so Siddha, it may be homeopathy, it may be Ayurveda, it may be whatever it may be, but in each and every state, okay, so we have at least one or the other centers. So this is the hierarchy, and then the what are the objectives, okay, so that has been mentioned by Honorable Advisor sir. The basic objective is, it is to generate awareness. Generating awareness is the important one. And after, okay, so generating awareness, okay, so we can go for the reporting, inculcating the reporting culture is the second one, and then so we have that another unique objective, so misleading advertisements, that is also there, okay, so which is an objective of the program, and all the details, okay, so I'm not going in detail of, okay, so those things, and the details, okay, so you can go to that website, and the maximum details, up to date details, okay, so they are available on that website. You can go there and you can see it. But okay, so basically, so what has been asked to me is to focus much upon the challenges. Of course, okay, so I was there, okay, so in this program since 2007, since inception, okay, so I know that, okay, so how this program was initiated and how this program was implemented, what were the practical difficulties that we have faced. So 2007 onwards, okay, so I am there in this program, so I know them that, okay, right. And so the challenges, if at all we are looking, you suppose, okay, so these challenges, we can categorize these challenges from the consumer point of view, right. So these challenges can be on behalf of the physicians, as a right, and then these challenges can be from the stakeholders, all other stakeholders. Fine. So these are the basic challenges that we have noticed, and challenges are there, okay, so in various other domains also. Fine. So we'll see it, okay, so one by one. So otherwise, okay, let us see it. So consumers, if at all we are looking to suppose, okay, so 2007 onwards, me and you may be knowing the Director General CCRAS Ravina Ranacharya, also, who was the national coordinator. I mean, he was a national coordinator at that time for that program, 2007. So we had a first-hand experience of interacting with various stakeholders since 2007, and so these were the what I can say, feelings that we otherwise, okay, so right, experiences that we could able to gather. People many a times, the consumers many a times, okay, so they feel that the traditional systems of medicines are safe. They are safe because they are coming from the natural sources. They are coming from the green sources. They are from the plant origin. They feel that, okay, so this is a plant, so plant is safe to me, so I can consume it. It won't create any sort of inconveniency. So why to report it? Why to feel that, okay, so it is going to create inconveniency? No. Right, they were not ready to at least understand that, okay, so this is a medicine, it's not a food supplement, it's not a nutraceutical, it's not a food supplement. Fine. So this is one, okay, so basic thing what we could able to realize when we had interactions with various patients, various consumers, that they never not in a position to understand that, yes, okay, so adverse drug reactions are possible even with the administration of herbal medicines or traditional medicines. So this is, okay, so one thing, so which we notice, this is the biggest challenge for us, biggest hindrance, okay, so in the development of the pharmacovigilance program. And then, so they don't carry any side effect, okay, so this is what they feel, this is what, okay, so that perception was there in the grassroots levels. Fine. So no supervision is needed while using these traditional formulation. They feel that whenever I'm feeling some inconveniency, okay, so it is in practice, it is in my, okay, so practice in my home, it is being practiced since decades or centuries. I know that, okay, so this herb is useful to me. They used to go to that market, they used to purchase and they used to consume it. That practice was there. They feel that supervision is not needed if at all I am consuming the traditional formulations, okay, so that perception, it was there. And they don't have any expiry. If at all it's a formulation, you suppose, okay, so they feel that, okay, so formulation is there, so that formulation can be kept in home for years together and that can be used. They won't expire, okay, so this perception, it was also there. They can be used for long. I'm a diabetic, for example, right, so it has been given by some physician, you suppose, and that can be used for years together. That can be used for years together, right? So if at all it is prescribed today, so I can use it for 10 years, 15 years, 20 years, lifelong. Right, that perception, that is also one specific thing. There is no dose limitations. They says that, right, consume as you wish. Consume, okay, so whenever you recollect that, yes, so my dose is skipped, right? So whether we have to take it for 2 times, 3 times, once in a day, there is no regulations. Whenever you feel that it has to be consumed, consume it, right? So this perception, it was there. Can be used with other drugs. I am using metformin ke saath mein, right? So you take, fine, Emblica, you take turmeric, whatever, right? So that can be consumed. So all these things, they are the misconceptions. So they are not true as such, right? So if at all they are following these things, you suppose, okay, so it may bring a bad reputation even to the system. Fine. So there is a possibility of any sort of inconveniency and any sort of, if any adversity is there, you suppose, okay, so these adversities will bring a bad name to the system. So that is, okay, so one awareness, okay, so lack of awareness, this was noticed, and on behalf of this is consumers. And similarly, physicians, when we were interacting, when physicians were interacted, okay, so so the first question which came to, okay, our notice is, they will ask what it is. Okay, so when we went to interact with the physicians, pharmacovigilance, they will first ask what it is. Do we need pharmacovigilance for us? We are traditional healers. We are traditional healers, right? So we are traditional healers. So whether we need, right? Do we really need it? Right? They will ask, okay, so हमें चाहिए क्या? Do we need pharmacovigilance system? Pharmacovigilance system is not needed for traditional systems of medicines because we are traditional healers. Traditional medicines are, right, free from side effects. Okay, so this is what, okay, so they feel, okay, so this is one perception which was noticed in the field of traditional physicians, Ayush physicians. It is for the modern medical systems. Fine. Adverse drug reactions are only noticed when, right, when conventional or prescription medicines are being handled. It is not for traditional healers. Fine. So this is what the perception which we noticed among the physicians. Okay, so will this really help? So kya hoga isse? If at all you are implementing the system, so what you are going to gain? Nothing is going to gain. आपको कुछ मिलेगा नहीं, right? So you won't get anything. Okay, so this is what we heard. What we will prove, क्या, right? What is going to? Okay, so what will be the outcome? Okay, so whether you are going to prove that, okay, so the systems are going to be harmful. Okay, so this is one, okay, so perception that we noticed in physicians. And similarly, okay, so this will bring a bad reputation to the system. So if at all we try to say that yes, traditional formulations are also going to create some sort of adversity, so it may create a bad name to the system, bad name to the Siddha system, bad name to the Ayurveda, bad name to the homeopathy. Okay, so this is the perception which we noticed in 2007. This will invite legal action if at all I am, right? So if at all I am reporting, you suppose, right, if at all I am saying that IMCOP's formulation has created this inconvenience or adverse drug reaction, so my terms with IMCOPS will go, and IMCOPS people, okay, so they may suit, okay, so they may initiate a lawsuit against me. Okay, right, so that, fine, perception was also there. Of course, gradually, 2007 and 2024, if at all we are looking, you suppose the system is changed now, the mindset is changed now, so at least, okay, so there are, of course, still, okay, so there are people, okay, so who speak, okay, so in these ways, but the percentage of people, okay, so who try to understand, okay, so they have grown up, they have, okay, so it is increased. Even, okay, so they say that, okay, so this is a conflict, okay, so that, okay, so is coming up from the otherwise, okay, so being planned by the conventional system of medicine. Okay, so this was also, okay, so we could able to hear. And similarly, okay, so that is in terms of a consumer, that is in terms of a physician. But okay, so when it come to policymakers, administrators, you suppose, right? Even today, okay, so the peripheral pharmacovigilance coordinators, if at all they are writing to the state licensing authorities, we know that how many state licensing authorities, how many drug regulators are supporting. The support is now, okay, right, so when Kaustubji, okay, so he took an example of Supreme Court's verdict, right? So there are, okay, so there are interventions from higher authorities, okay, so then, okay, so at least state licensing authority, they started to at least hear us. We have 40 to 43,000 cases of misleading advertisements which have been reported. It is huge, right? It is huge, 43,000 cases. And how many actions have been taken up? Meager. I can say that 2,000 or 3,000. Against 40,000+ cases, only 2,000, 3,000 have been cleared. That too in a very few states. So the support from the authorities is meager. So that is where, okay, so we notice that this is one of the biggest challenge, that, okay, right, support from the administrators, support from the, right, policy makers is very much essential. Initially we faced it, but now the system is gradually it is changing. Resistance from the various stakeholders. Okay, so these things we have noticed. And besides all these things, besides the, okay, consumers myth and right, the physicians practical difficulties, there are many more. Once, if at all, okay, so they have convinced, you suppose, once they have been convinced that it has to be reported, once, okay, so they came to that, okay, so area of reporting, you suppose, then there are many more practical challenges, difficulties. Every individual is unique, okay, so in traditional systems of medicines, okay, so whenever they are, right, handling a case, you suppose, whenever they are treating a case, you suppose, managing a condition, you suppose, it doesn't mean that it's a fever and paracetamol is given. It's not like that. Each and every individual is unique, right? Disease may be disease, it may be fever only, but the battery of medicines that okay so flows in front of you is n number depending upon that specific condition. Okay, so you may be using various medicines for that specific condition. In Ayurveda we have for fever at least okay so 25-30 medicines are there today. Okay, so one medicine may be suiting to me, but tomorrow so it may not. It may not. Okay, so it depends upon various factors, depending upon that constitution, that unique constitution, depending upon those factors which are supposed to be right analyzed before administering any sort of medicine. It depends upon that. So in case of conventional medicine, so it is simple, right? So it is fever, so just give acetaminophen, finish. But for our case, it's not. So this is one biggest challenge that we faced, because of which that Naranjo's algorithm, it is becoming difficult to us to at least implement. Fine. So that's why. So this is one unique challenge that we have faced in traditional systems of medicines while implementing this pharmacovigilance program. And this is okay. So I mentioned herbal medicines. Okay, so they are not food supplements. They are not food supplements. They are not right. The dietary supplements are, they are not the botanicals. Okay, so they are the medicines. They are supposed to be considered as medicines. They are supposed to be consumed under the supervision of a qualified physician, qualified Ayush physician. If it is Siddha system of medicine, go to the Siddha physician. If it is Ayurveda, go to Ayurveda physician. It is homeopathy, go to the whatever it may be, but it has to be consumed under the supervision of a qualified physician. If at all he is not a qualified physician, you suppose, okay, right? So we cannot consider it as a. I have hundreds of such kind of examples by sitting. Okay, so in this under this roof. Okay, so you can open your mobiles and you can search for classical formulations being marketed without registered licenses. I can show you. Okay, so various examples. There are certain backdoor entries, right? So there are certain backdoor entries. Okay, so by using those backdoor entry licenses, okay, so these products are coming into the market, and these products, if at all they are using, if the consumer is using, if something is happening, you suppose, who will be blamed? Then the system will be blamed, right? So they won't blame that product as such. They won't blame that registration cycle as a whole. They will blame the system. They will say that Siddha system say, right, adversity ho gaya. That casualty is because of the Siddha system of medicine. That thing will come. So that's why, okay, so we need to be very careful. So though it is a herbal in origin, though it is a traditional formulation, though it is a right Ayush product, so these products are supposed to be considered as a medicine, considered as a formulation, traditional formulation, scheduled formulations. They are supposed to be consumed under the supervision of a qualified physician, unless, okay, so they are not supposed to be. And complexity of formulations. This is a very big difficulty that we are facing since last many years. It's not easy to generate a fingerprint for a single ingredient formulation. I'm talking about single ingredient formulation. Then think about the multi-compound formulation. Chyavanprash, for example, 50 plus ingredients, right? So what will be the ideal otherwise, okay, so right quality profile for that specific formulation? It is very difficult. And use in combinations along with specified. That's what, okay, right? So if at all it's a fever, you suppose, okay, so I given that example of acetaminophen. But okay, so if at all it is a fever in case of Siddha system of medicine and he's consuming Siddha medicines, you suppose, then you have given 5 or 6 medicines. You suppose these 5 or 6 medicines, they are compound formulations. We don't know how many molecules are there, which molecule is going to interact with which molecule to break that pathology, that we don't know. That pharmacodynamics and kinetics are not well established in modern lines. We know that, okay, so by possibly by, okay, so interacting with this specific phenomena, okay, so that disease is coming down. But if at all a conventional scientist is there and if at all he want to understand, you suppose it is very difficult. So such kind of monographs, otherwise fingerprints, such kind of evidences which can convince the global community, so they are not there with us. So that is one challenge that, okay, so we are facing at this moment. And OTC availability of these products, I mentioned it. They are not the food supplements. They are not the dietary supplements. They are the formulations, but they are available on the market. They are available in the market with some other registrations. Over the counter availability of these products, it is another challenge which the pharmacovigilance program, not only the pharmacovigilance program, entire Ayush system is facing. Right? So these OTC products, okay, so they may create various sorts of inconveniences, not only the adverse drug reaction, but there are many other issues which which the consumers can, right, come across. And these products are available over the counter, and at the same time, so in many of the formulations, there are no package inserts. Package insert, if it is there, you suppose at least, okay, so if at all I'm purchasing that formulation from the market without any valid supervision, without any valid prescription, if there is a if there is a package insert, at least I can read it and I can understand where that formulation can be used, in what frequency it is supposed to be used, in what dose it is supposed to be used. Are there any specific instructions, further instructions? Are there any specific regulations to be used? Whenever I am using those formulations, you suppose, so what kind of other diet and lifestyle, right, restrictions or instructions are supposed to be organized? Okay, so these things are supposed to be there. Okay, so and many of the OTC products, so these package inserts are not available. This is one biggest challenge that, okay, so we are facing, and market is not properly regulated. That's why, okay, so these products are coming into the OTC areas, and carelessness thinking it to be safe. This we have mentioned that consumers many times, okay, so they feel that these formulations, okay, so they are safe, and that is one challenge. The other challenge, okay, so that we can see is the interactions. That's what I said. Okay, so if at all I'm a diabetic, I'm already on insulin, right? I'm already on insulin, and along with that insulin, if at all some Siddha medicine I am using, you suppose, do you have any guarantee that, okay, so this Siddha system of medicine is not going to interact with insulin, so that there may be two kinds of interaction then. One is synergism and second one is antagonism. Okay, so if synergism is there, so then also it is a practical difficulty, and if it is antagonism, then also there is a chance of inconveniency. So do we have any documentation to say that yes, okay, so this herb drug interaction is not possible? No, unfortunately, the documentations are not there. Not only with Siddha, but for even with Ayurveda also, we don't have any such kind of systematic documentations to say that yes, okay, so this Ayurveda formulation is not interacting with the antihypertensive drug. This, okay, so Ayurveda formulation is not interacting with the anti-obesity drug. No, we have no such kind of documentations, right? Herb drug interaction documentation is not there, and people now they are coming up with herb interactions, right? You are giving Siddha one medicine with one Ayurveda medicine, for example, or two Siddha medicines you are adding, you suppose. So our experience is that, okay, so I am in practice of Siddha medicine since last 20 years. They are safe, right? So if at all you are combining these two formulations, nothing will happen. That is my experience. Depending upon my experience, I am prescribing it. But whether it is on paper, no. So these experiences of focus, all these, right, experienced physicians, it has to come out. Somewhere you can say that these are the combinations which are frequently being used in the practice of Siddha system of medicine in CCRS, which are safe. You can use it, okay, so safely, nothing will happen. At least, okay, right, so clinical evidence says that the battery of liver functions and hepatic functions are safe. They can be used in combination for this much of time. For 3 months, if at all you are using, nothing will happen. That experience, if at all it is coming out, you suppose, okay, so even that can be a valid documentation. So we don't have that herb interaction, okay, so databases. And then herb food interactions. There are specific foods, at least, okay, so in Ayurveda it is mentioned that, okay, so whenever you are using this formulation, don't take the food which is sour in predominancy. They will say that don't consume salts. If at all I am consuming, what is going to happen? That we don't know. Okay, so that's why, okay, so these interaction studies, otherwise systematic evidences against the possible interactions with in between herb formulation, herb drug interactions, that is not available, and whatever is available is very minute, we can say. So it's meager. It's just like a tip of the big iceberg. So huge amount of work it is supposed to be done in that specific domain. And coming to this manpower, we don't know. We have skilled, okay, so skilled pharmacovigilance manpower, no. Even we can say that yes, we are functioning since 2017, but we are not still skilled, not skilled. We are working, we are trying to at least, okay, so imbibe the culture. We are trying to generate awareness regarding the understanding of pharmacovigilance program for traditional systems of medicine, but still, even today, right, so we're not skilled manpowers. Okay, so we're not skilled, okay, so pharmacovigilance professionals. Still, there is a huge amount of time which is supposed to be scaled up, right? So we have to do much more work, right? So this is one challenge that we are facing. And databases, this is what I was mentioning. Okay, so if at all, okay, with one Siddha medicine, suppose, so one adverse drug reaction is reported. So do we have any database to compare whether we have any similar cases previous also, whether any reports are there with us? That's what madam was mentioning. Okay, so as of now, okay, so we are working since 2018, so we have 300 plus. I'm not saying that they are the adverse drug reactions. They are the suspected adverse drug reactions. We are suspecting that it may create some sort of inconveniency. I'm not labeling them. Of course, okay, so Upadhyay, okay, so he mentioned that these reports are supposed to be analyzed. We are at the verge of analyzing, okay, so those things. But those adverse drug reactions, if any, they are supposed to come to the to the open domains. So if at all they are coming to the open domain, you suppose if there is a battery of adverse drug, suspected adverse drug reactions with these formulations, if it is there, and in my clinical practice, if at all I am noticing that, yes, okay, so this is a new inconveniency that is being reported with the use of this formulation. So you can see that is okay, so it is there in the national database, and so it is not new then, right? So you can say that yes, you can report it, you can say that yes, okay, so I also notice such kind of inconveniency. So databases as of now, okay, so they are nil. So definitely I can say that they are nil. Even the research articles, they are also very few. There are very few. Okay, so since 2018, okay, so we are working in this field. So for the knowledge, attitude and practices, okay, so there are few publications they have came up, at least, okay, so 8 to 10 publications they have came up with different, okay, so stakeholders. Okay, so there are homeopathy people, Siddha people, and Unani people from Ayurveda. Okay, right. So there are publications, but these publications are also, they are basically on knowledge, attitude, KAP kind of surveys, not the publications on the adverse drug reactions. There are very few. Whatever the reactions that are available, they are very few. So this is also again so one challenge for me, right? And then so this is the biggest challenge. Then stakeholders are there here, state licensing authorities are there, or drug regulators are there for them. Okay, so this is one biggest challenge that we are facing. And what this document says, okay, so you can see this document, 2019 document. Okay, so they have enlisted what are the challenges, right? All these things are challenges. All these things are challenges for the global UN member states, not only for India, but okay, so for the all those 194 member states. Okay, so these are the challenges. Okay, so WHO is asking, do you have any documentation? Do you have any research data, right, on that specific domain, whatever it may be the domain? Okay, so they are asking, do you have any scientific data to say that yes, okay, so my formulation is useful in managing diabetes? Do you have any data? So if data is there, please submit us. Okay, so that they are saying. Similarly, okay, there are many. Okay, so the battery of questions, you can read it, you can understand what exactly WHO is willing to have information from the traditional healers, that you can see. And then okay, so I'm focusing upon this one, right? So lack of mechanisms to control and regulate traditional medicines advertising and claims. This is one important area which has been rightly focused by the World Health Organization. So in this global report, it's again okay, so this report is also open in domain, open domain, that can be downloaded so that you can see it, and you can see that report what they're saying. Of course, that report belongs to 2012, almost 12 years back, right? So almost a decade back. Okay, so they said that this unregulated claims, so they have been escalated almost 6 times, right? 2005 to 2012. Okay, so they have been escalated to 6 times almost. So it indicates that there is a huge demand for the traditional medicines across the globe. So that's why there are such kind of practices, right? Unregulated claims are coming up drastically. Okay, so this is what it infers, and it is, that's what I said. Okay, so such kind of misleading advertisement, they are rampant in the society, not only in India, right, but across the globe. Okay, so this practice, objectionable advertisements, okay, so they are rampant. And then so generally, usually, many a times, around 70 to 80% of such kind of advertisements, okay, so they are ineffective. Okay, so they want to only do the business. So they such kind of products, if at all you are using, you suppose they may carry adverse drug reactions. Always there is a possibility. So that's why, okay, so we need to be very, very careful. And what we need to do, okay, so so the awareness is very poor. Awareness is poor. I shouldn't say very poor, because when I'm comparing to 2007 to 2017, awareness is there, but still there are physicians, there are stakeholders, there are consumers who still feel that, right? So traditional formulations are safe enough. They feel that. Okay, so even the reporting, okay, so mechanisms, they are, okay, so if at all I'm looking, you suppose 2018 to 2024, 6 or 7 years, we have 2700 plus such kind of suspected adverse drug reactions reporting is there. 2000 is not a huge number. Okay, so still, okay, so there is a huge number which is supposed to be scaled up. And for that awareness, for that increasing awareness, okay, so such kind of programs, okay, so this is one program which has that objective of increasing awareness of so the pharmacovigilance program. And so these programs are supposed to be conducted. I'm happy that, okay, so in this pharmacovigilance initiative of government of India, we have conducted more than 2500 plus such kind of awareness programs in these 7 or 8 years. So sensitizing more than 2.5 lakh stakeholders. Of course, okay, so I cannot say that it is huge, but okay, so some initiatives, okay, so we are doing it. And human resources, that's what I said, that okay, so the skilled manpower, okay, so it is very less, and we need to sensitize the policy makers to generate skilled human resources in that specific domain and direction. And the responsibility is, you cannot say that, okay, so government of India will do, otherwise Kaustubji will do, okay, so who is sitting in the drug policy section. It's not like that. So it is the responsibility of each and everyone. I cannot say that, okay, so he will do. It's my responsibility, it's your responsibility, it's her responsibility and his responsibility. It's everyone. If at all we are joining hands together, you suppose, then only we can change the system. So if at all we are sitting idly, you suppose, okay, so the change, it will not come. Right? If at all you want to see the change, you suppose, in systems, we have to run. Until and unless, if at all we are not running, so it won't change. So that's what I said. The responsibility is everyone's responsibility. It is, right? Each and every individual, let it be a professional or non-professional. So professional is prescribing, non-professional is consuming. So the consumer and the prescriber and the stakeholder and the policymaker and the administrator and the pharmacist, everyone has equal responsibility to strengthen the program. And improving, that's what I said, it's a voluntary participation of all healthcare professionals. They have to come, they have to join hands together, then only, okay, so some change we can see. NCISM and NCH, National Commission for Indian System of Medicine, and National Commission for Homeopathy, okay, so what they can do, so they can add it into the curriculum. Of course, in 2007 itself, okay, right, so we could able to convince the CCIM at that time, Central Council, we could able to sensitize them, we could able to convince them, because of which, okay, so it has become a part of postgraduate curriculum. Pharmacovigilance became postgraduate curriculum. And now you may be knowing about the minimum standards, right? MSR, you might have noticed it. So now pharmacovigilance, it became a part and parcel of MSR, minimum standards required for maintaining, for managing academic colleges, right? So pharmacovigilance, establishing pharmacovigilance unit is mandate now. Fine. So NCSM is taking efforts, right? Efforts are there on behalf of NCSM, efforts are there on behalf of NCH. Again, efforts are there, they have made it mandate, but then who will work? You people have to work. We people have to work. So if at all the colleges and if at all the peripheral centers are joining hands together, you suppose, then again, the system, we can take it to the next level. That is very much essential. So safety studies to be encouraged at research level. So safety that's what I said. Okay, so WHO, so this says that, okay, so not now, okay, so almost 15-20 years back itself, okay, so they say that yes, there is potential is there, but if at all I want to implement, you suppose I need documentation. If at all documentation is needed, you suppose you need to do some systematic research. So you have to do, okay, so that systematic research, and you have to come out with safety profiles, efficacy profiles, and quality profiles. If safety, efficacy, and quality profiles are not there, you suppose it becomes very difficult to convince the governments. And information on these interactions, herb drug, herb food, herb interactions, this data is supposed to be, let it be cytochrome P oxidase studies, or let it be, okay, so in vivo studies or in vitro studies, clinical trials, whatever it may be. Fortunate that, okay, CCRS, you may be having clinical units, NIS is there, postgraduate curriculum is there, PG studies, PhD studies, they used to do it, okay, so they can say that, okay, so in these concomitant use, the biochemical profiles, right, the hematological profile, the renal profile and hepatic profile, they are not altered, they are maintaining their healthy range. That itself is a evidence to say that yes, this combination, this formulation, if at all we are using, if at all we are prescribing for a month or 2 months, it is safe. right? So those outcomes are supposed to be documented and they are supposed to be published. Until and unless if they are not publishing, again, so it becomes very difficult. This is what I'm mentioning. Use standard terminology across the across the Tamil Nadu. All Siddha physicians, if they are okay, so I don't know whether they are using standard terminologies or not. Okay, so that is very much important. Okay, so it has info. I mean, so it has came into right knowledge almost 10 years back, right? So Ayurveda physicians across the country, so we are using different terminologies for one specific modality. For example, diabetes. What is the Ayurveda term which is approved for diabetes? Which kind of term is supposed to be used? If at all we are using similar kind of term across the country, you suppose, then systematic documentation will come out at the end of that year. How many works have been done in that specific domain? Okay, so that outcomes will come. So that's where the WHO, it has came out. ICD 11, you may be knowing. So from Siddha, okay, so there are servers there. Okay, so in Malaysia last week. Okay, so for that specific activity. So those terms, okay, so you are supposed to be used, which have been approved and accepted by the government of India, right? So use those appropriate terminologies, standard terminologies, so that we can come out with the systematic outcomes. Training of pharmacovigilance reporting is very much essential. Awareness is, of course, okay, so we're doing it, but besides awareness, okay, so we need to have pharmacovigilance training programs, particularly in casualty assessment. Of course, reports are coming, then how to analyze it. So what are the shortcomings in the reported which have been received? Okay, so these analysis is very much essential. That okay, so is way ahead. Okay, so we are planning about it, and developing casualty assessment scales which can suit the traditional medicine. That's what I said. Naranjo scale as such, whether we can adopt it, no. So there are certain practical difficulties. If practical difficulties are there, you suppose, okay, so which scale we are supposed to be used then? So whether we can modify it, which can suit to my system of medicine. Okay, so that is one way ahead. And then many regulations to take action, okay, so on the advertisement. This is one important area, of course. Okay, so when advertisements are there, when misleading advertisements are there, when magic remedies act is there, you suppose, objectionable advertisements are there, you suppose. Okay, so many a times the state licensing authorities or regulators, only they used to focus upon DMR, Drugs and Magic Remedies Act, but it's not the only act which is existing. So we have at least 5 to 6 different acts, okay, so which are supposed to be considered, right? We have Consumer Protection Act. Why don't we consider it, right? We have Ayurveda Ahara, food regulations, FSSAI regulations are there. Why can't we use it? Cable and Television Network Act is there, so why can't we use it? Definitely, right? Young Persons Act is there, so why can't we focus upon that? We can't only limit to DMR. We cannot say that this misleading advertisement is not pertaining to my area because DMR, it never spoke about, okay, so that specific entity. It's not like that, right? So there are many, okay, right, acts, okay, so which are supposed to be considered. So that area, that domain is supposed to be broadened, so that such kind of, okay, so we can curb the, okay, so practices of such kind of misleading advertisements. This is what I would like to put forward in front of this august audience. And thank you so much for giving me that wonderful opportunity. Thank you, Muthukumarji, and all the administrative authorities of CCRS. Thank you so much. Queries are there? If any questions, if at all you are having, you suppose, please, I'll be happy enough.
Morning, sir. Sir, you were talking about the objectable advertisement, right? Can we publish the research data what we have done, and then we claim that this drug can work for this, like particular disease? The formatted one, what we have formatted for our. Yeah, I know.
It's a PNP, not proprietary, otherwise a patented. Yes. See, what we feel is all the new entities, they are new chemical entities. 2018, okay, so there is one act which was released by CDSCO. So it says they have given, okay, so how the drug development is supposed to be done. And so if at all you want to market that new drug, you suppose, what are the preliminary, okay, so satisfactory documents you have to generate. So you may be having a quality profile, you may be having preclinical efficacy, you may be having okay, so preclinical safety and all those things. Definitely, the outcomes are supposed to be published, so which will be in your favor wherever you are going. Okay, right? So you are marketing it. So while marketing, if at all you are selling it for some other big industries, you suppose, so definitely okay, so they will see so whether you have documentation or not. If at all you have the documentations in house, you did that experiment, you have that okay, right, all those profiles with you. But if it is there okay, so in your company, you suppose okay, so who is going to be benefited? Only your company. So if it is coming out, if it is publishing, you suppose across the globe, people they can see and what quantum of huge work okay, so which has been done by that XYZ company to launch that specific product. So ideally, so it has to be published. For me, it has to be published.
So we have published that also, but still, if we can be advertisement that research whatever.
Advertisement, see, so advertisement, why it is to be advertised? Why it is to be advertised? Okay, so advertisement is for the business purpose. Why that business? And if at all, okay, so you are advertising it. I am sitting in a different corner of the globe. I saw that advertisement and I purchased it. I have no valid prescription, and I have entered into a condition so which is unintended. You suppose, then who will be responsible? It is your product, and I have collapsed after consuming that drug, for example. So who will be responsible for my life?
The purpose of the industry is to survive, right? So the purpose of the industry to we have to do some business.
See, this is not for business, right? So medicine is not for the business.
Of course, if the industry is not that, the medicine is not going to be there.
Fine. See, so that's what. Okay, so for my business, I cannot keep the life of the individual at stake. Fine.
I'm not talking about the side effects. I done a research on a particular product. And I published that also. So now can I claim I can give this particular product?
You can say that. Okay, so as a scientist, as a researcher, care professional, you can say that this product is safe, this product is good, this product has this much of efficacy in that given therapeutic, in that given pathological entity. That's it. Based upon that efficacy, otherwise based upon that specific evidence, you cannot claim and you cannot say that, you cannot put it on paper that it has wonderful anti-diabetic properties. It is wonderful. I mean, it is very useful in treating that specific disease condition. Let it be cancer or diabetes or whatever it may be. Because see, so when we are living in a scenario, when we are living in a situation, we are in Indian scenario we are living. So I have to respect my right administrators. There are certain gazettes. So those gazettes are supposed to be right respected. I have to respect it. If at all I am violating, you suppose, then I'll be punishable then. I cannot say that, okay, so, I mean, this is for my sake, for my business sake. When there is a gazette, that gazette has to be. There are 54 disease entities. For those 54 disease entities, you cannot claim, right? Another thing, in those 54 disease entities, obesity is there, for example, and your drug is for obesity, you suppose. You are not using that term obesity, right? So you can say that, okay, so you are advertising that your product is reducing the hip waist circumference. Ultimately, it is obesity, right? So your work is done and you are not even violating the regulation. Fine. So there are many such kind of instances, but be ethical when we are doing any sort of advertisement. So think that, okay, so for my business, I cannot right put the society at risk. Fine. So that is the moral of that specific this one, because we are human beings. Knowingly that, okay, so for my sake, for my business, for my livelihood, I cannot make the others at suffering the end. I cannot leave them for a medical claims. It shouldn't be. It shouldn't be, because there are many. That's what I say.
Good afternoon, sir. So very happy to meet you here. So thanks for giving a very big picture about the pharmacovigilance. And in the last slide, I think last slide, you put some way forward approaches for better implementation of the pharmacovigilance. So actually, sir, there is a big lacuna in our Ayush industry. That is, only the manufacturing process is being regulated. The manufacturing of the medicines, manufacturing industry is only being regulated. Whereas in the allopathic side, bulk drugs, manufacturing industry, and also sales part, all the three parts are regulated. But here, there is no license for raw material sales, and also there is no license for this medicine sales. Only manufacturing is regulated. With this system, how the regulators can effectively implement the DNC Act in the raw material side, that means the raw material sellers and also the medical shop sellers. So the platform like pharmacovigilance, which is doing a wonderful job throughout the country, you can suggest to the drug policy section to speed up the process of the implementation of the license, both to the back end raw material side and the front end medical side. So this is my humble submission to you.
That recommendation. So I mean, after at the end of the 2 days, so the recommendations will come out. So these recommendations definitely will. I feel okay, right, Mr. Kumarji. Okay, so they will forward it to the drug policy section. Kaustubji is there anyhow.
Yes.
So we'll see it. Okay, so you're also one of the leading stakeholder, otherwise policy maker. So definitely, I mean, so we'll join hands together in that noble endeavor. We'll
yes, sir. And for information, sir, actually, the government of Andhra, they have implemented a sale license to the sellers, medical shop sellers.
Right.
It comes under the sale license and it's doing effectively. Right. They have closed the shops, those who have not got license, even for 1 week, 10 days, 1 month like that.
Yes, I know.
So this is the thing.
Yes.
And secondly, sir, coming to the DMR Act, so you are told about 54 diseases, sir. I think this DMR Act was framed considering the allopathic system of medicine. Can we have a separate DMR for our Ayush medicines? Why? Because I'm telling, in out of the 54 diseases, one is ulcers of the gastrointestinal tract. So everybody here and you of course knows Ayurveda and Siddha, entire Ayush system can do well with the gastrointestinal tract ulcers, but it is given there. And the another thing is the disorders of the menstrual flow. So we are treating menorrhagia, metrorrhagia, and amenorrhea also. So these classes, I think it's not synchronized with the Ayush system. So experts and other people can say opinion about that.
So of course, 1954, almost 50 plus years, right? 70 years back. Okay, so it was notified. I do agree. Okay, so whatever you mentioned is right. Not only these 2 or 3, but there are many occasions. There are many pathological entities which can be, I can say that cured, not managed. Okay, so we can cure them, but as sir was mentioning, so we cannot claim that. We cannot claim that because okay, so that is existing act. We have to respect it. And the 2020 February. So one amendment was made in this Drugs and Magic Remedies Act. Since last 4 years, it is pending.
Yes, sir.
So
yes, sir.
Those number of diseases they have elaborated. Okay, so new entities. Okay, so they have been added, but it is not yet notified. So let it come out. So let us see. Okay, so it is there. That draft is also a new draft is also available on the net, so that you can see it. Okay. So there are certain diseases which have been removed.
Okay.
And there are few diseases which have been added.
Have they considered the Ayush system while drafting this, sir? Or,
not as such. Act is for everything, for the healthcare system.
Okay.
For Ayush, there is no specific act again.
Okay. Thank you, sir.
Thank you.
Sir, I would like to express my views about this DMR.
No, it is from that mouthpiece.
I would like to express my views about the DMR in regarding the enlisted diseases, sir. I think, is it based on the recurrence or something like that? Can we assure the ulcer will be cured, but we cannot assure the recurrence of the ulcer? So in that matter only, it has been listed in the Magical Remedy Act, I think so. Maybe. Is it right, sir?
Maybe. So that's what, see, I would like to, one general point, I'm not speaking about the DMR amendments and all those things, but whatever it may be the Gazette, whenever they releases, they in the sense the government releases, whatever it may be the government, it may be Ministry of Ayush or it may be Ministry of Health or it may be FSSA or whomsoever they may be, SEDESCO, whomsoever. They used to keep the draft gazettes, draft documents, draft technical reports on their website. Openly, they will keep it for a 1 month, 2 months, 30 to 60 days. They used to keep it on the website, inviting comments from the other stakeholders. We are the stakeholders. So then our responsibility is to at least comment that yes, okay, so this is right, this is wrong, okay, so this amendment is needed, modify this so and so. So that we have to do it. If we're doing, you suppose, okay, so they will understand what exactly Siddha system is needed, what kind of amendment is needed from the Ayurveda point of view. Okay, so that is how we can make changes in the systems. So that is, of course, I do agree with what you mentioned. So that is the one basic reason. Okay, so how, okay, so they are enlisting the diseases, are okay, so finalizing the disease list. Now it became 80. I feel so. It is 80.
One more thing, sir. One more thing. You have mentioned the lack of awareness in public, in common public. Is it, sir? But my view is, even drug manufacturers and pharma companies also the same scenario. I think so. In the same platform, they are also having the myth that is herbal drugs are not highly safe and there is no expiry, and they won't have any drug interaction with food or something like that. Is there any amendment which compels the pharma companies to have the knowledge about the pharmacovigilance like this, sir?
It is there in Drugs and Cosmetic Act. You can open it. Okay, so huge amount of references are there in DNC Act.
But
where it is mentioned that it is post-marketing surveillance se leke, pharmacovigilance se leke, what kind of data, what kind of documentation they need to, okay, so keep it in their records. It is mentioned. Though it is there 1940, 1945. So, right, so it is there. The system is there. Okay, so existing law says that, okay, so you have to have those documentations. But again,
okay.
you can understand it. Thank you so much.
Thank you, sir. Thank you.